Okay, welcome everybody to season 2, episode 2 of Transformation Weight Control podcast. I'm joined with my co-host Alex
Hello.
Tashinsky and Dr. Dympna Gallagher, who I'm going to introduce more formally in a few moments. But let me say this before you move on. If you want to know all about body composition and body fat and muscle and some bone, and you want to know the optimal amount and what it does and how to measure it at home, and all kinds of questions related to that and what your body's made of, well, we have one of the world's experts truly in the world. Dr. Gallagher and I worked together for 25 years at the New York Obesity Nutrition Research Center at St. Luke's in New York City, and she is really on the ball and really knows her stuff. And I was telling Alex before that maybe this woman has done more DEXA scans to measure bone density and so forth, and maybe anybody in the world, and visceral fat and body fat and everything. Just amazing. So we'll have lots to talk about. Let me just quickly tell you that Dr. Gallagher is professor of nutritional medicine and the director of the New York Nutrition Obesity Research Center at Columbia University. This is the very first Nutrition Obesity Research Center that was founded back in 1979 at St. Luke's Hospital, and then it moved uptown. So it has a long, prestigious history, and now Dr. Gallagher is the director of that, and that is quite a thing to say about someone. She's also the director of the Human Phenotyping Core, which includes body composition laboratories and human metabolic chambers. And maybe I'll ask her what phenotyping means for those of you who don't know it in just a moment. But her research, and she has published, she sent me her resume and there were 26 pages. So there's, close to 200 publications or more. She's mentored dozens of students, and she's been teaching since 1990. She went to college in Ireland where she grew up, I think, right? Didn't you grow up? You grew up there. Yeah, and then she got her doctorate, her master's degree and her doctorate in advanced exercise physiology at Columbia University in New York City, and has been in New York City, I guess, ever since. When you hear her speak, you get incredibly impressed very quickly. She also just very quickly was recently awarded the very prestigious 2025 Forbes Lecture in Auckland, New Zealand, in recognition of her international and leading long-standing contributions to the field of human body composition. And they don't give that to just anybody. So we really are sitting here with an expert. So if you want to learn a whole bunch about this and not listen to something online that isn't true, don't click away, because you're going to get the truth, because she really is the real thing. So, okay, very quickly, just tell people what the phenotyping core is, because I have to believe nobody's heard the word phenotype before.
So it's essentially, well, first of all, thank you, Rich.
Go ahead.
It's a pleasure for me to be here and to talk to you today. So phenotyping essentially is a fancy word for measurement. And in terms of what we're measuring, it's human measurement. We also have an animal phenotyping core, and I'm not a part of that. So phenotyping, within this core, we quantify body composition in humans. We quantify energy expenditure, either resting or total energy expenditure. We also have the ability to, through a adipose tissue subcore within the human phenotyping core, to characterize adipose sites. We have an imaging analysis laboratory or subcore that Dr. Shen is the director of for human studies, where we measure body composition by MRI. Analysis can be performed of many of the depots and organs that are considered to be important, and we will talk about some of those today.
Okay, great. Thank you. Dr. Gallagher's research is dealing with weight loss and weight regain, obesity, aging, type 2 diabetes, weight loss surgery, pregnancy, and even ethnic differences in body composition, which is a very big and important area, particularly when it comes to health, as well as in children and infants, which is very interesting to consider that you're measuring body composition in small little human beings. So Dr. Gallagher can talk about that as well. Okay, so I thought what we would do first is just if you could just tell us how you got interested in this, because honestly, like I went through biology, I did it. We never talked about, body composition, muscle, body fat, bone. What got you focused on this?
So I think I was in the right place at the right time. And by that I mean when I was finishing up my doctoral degree, which was, as you say, in exercise physiology, my mentor at the time proposed that I consider doing postdoctoral training. And that I'm talking about an era where doing postdoctoral training was not something that I had known about. And some blocks from St. Luke's from blocks from where I was doing my research, was the St. Luke's Russell Hospital. And Dr. Stephen Himesfield was one of the researchers there, and he
Sure.
was director of actually the core that I'm now director of here. And I was successful in applying and being accepted as a postdoctoral fellow to train with him. And this
Okay.
was level of expertise.
All right, great. So a little bit of serendipity.
Yes,
And
correct.
Dr. Himesfield, for those who have never heard of him, and you may not have, is one of the world's leading scientists in the world related to obesity and so forth. So Dr. Gallagher comes from very good pedigree and training because Steve is one of the world's real experts as well. Okay, can you just sort of give us just an overview of body composition for people before we dig into it? When you think about body composition, what goes through your head? Is it muscle? Is it bone? Is it fat? Tell us the components.
So when we measure body weight, and we do this, many people do it daily, every time we go to a physician's office, what is weight really referencing? Body weight is the sum of multiple tissues and organs in the body. And what we know is that increased weight, for example, is associated with, let's say, metabolic risk factors. But what components of body weight are more associated than others? And that's where we need to break down body weight into, let's say, fat and the non-fat compartment. Now I'm talking about a two-compartment model when we think about measuring. I want you to keep in mind that fat is a relatively homogeneous compartment. Fat-free mass is not. And while many people listening today will think of fat-free mass as muscle mass, yes, muscle mass is maybe 45 plus percent of fat-free mass, but it is not all of fat-free mass. There's other organs and tissues that constitute the remainder of fat-free mass. So when we talk about adipose tissue or fat, and those terms are often used interchangeably, we also need to be cognizant that fat is deposited in different depots of the body. And why that is important relates to the metabolic characteristics of certain fat or adipose tissue depots. Some are associated with greater health risks than others.
So are you talking now about visceral fat and subcutaneous fat? Is that what you're
So,
getting at?
yes, visceral fat, subcutaneous fat, intramuscular fat, or adipose tissue. Some people may read the literature and they'll see it's adipose tissue we refer to. There's the term ectopic fat, epicardial adipose tissue is also a component there. So not all fat is equal.
Okay. I know that people probably may be familiar with the term visceral fat. We don't need to
Yes.
speak about all the different types, but could you speak for a moment about visceral fat and the significance of that because it's very
Sure.
important metabolically and so forth?
Yeah,
Sure.
that's the only one I know.
Okay, interesting. So visceral fat is found within the abdominal cavity. So if you think of waist circumference, what are we measuring? We're measuring the circumference of the waist. The first depot under the skin is subcutaneous adipose tissue or subcutaneous fat. Then there's a muscle layer, and underneath the muscle layer, you have visceral adipose tissue that surrounds the organs that are in there. So that adipose tissue depot if you were to ask me, well, in a normal, healthy weight individual, how much is in there? I'm going to say to you, 3/4 of a kilogram in young, healthy adults, maybe even half a kilo. However, as individuals develop excess weight or gain excess weight, it's not unusual to see 3 kilos. I would say 5 kilos would be at the higher end of what would be what I've seen. That said, I'll stop there with regards to visceral. I have seen 11 kilos in individuals before going for bariatric surgery. So that is what visceral adipose tissue pertains to.
Right.
If I may just
Yes, go ahead.
if I may just add that, what's the metabolic profile of this? Why is it that we think of it as being negative? Well,
Right.
the visceral adipocytes are linked to higher metabolic activity and insulin resistance, whereas subcutaneous adipose tissue is less metabolically problematic or negative. The health risks associated with visceral adipose tissue there are pro-inflammatory properties, and they also affect perhaps immune response. So it's negative. And there's very well established epidemiological data to show that as visceral adipose tissue increases, several well-known metabolic risk factors increase as well. And when you reduce visceral adipose tissue, you see a reduction in many of those.
Right. So when we're talking, or you're talking about an excess amount of visceral fat, where the phenotype of it, the end result is diabetes, type 2 diabetes, fatty liver disease, cardiovascular disease, blood pressure, those sorts of things. Is that what you're saying?
That is correct.
That's why you're saying it's so problematic.
It's correct.
Compared to the subcutaneous fat, which is below the surface of the skin, but not as dangerous.
So correct. So the subcutaneous adipose tissue, its function is storage. However, it's also padding or protection. However, it has less metabolic risk compared to visceral.
Good, right. So before we get to how you measure all of these things, which I really want to talk about, what would someone who's listening to this go, oh, geez, how do I reduce my visceral fat? What would I do? And is it the same as reducing my subcutaneous fat? What do I have to do here to make myself metabolically healthier?
So it's I would I would say dietary changes to depending on the weight of the person to begin with. There are individuals who have visceral obesity, yet they are lean, meaning they don't fall into the obese category. Okay, so you can have a large waist circumference, okay? You can step on a scale and your BMI may place you in the overweight category and not necessarily in the obese category. I want you to understand that. Similarly, and I don't want to confuse you, but there are also what is called the metabolically healthy obese individuals.
Right.
Okay, so yeah, let me allow you to continue.
No, okay, no, you make some really good points because I mean sometimes we just look at someone and just based on their mass, we think, oh man, they could be terribly unhealthy, but that's not necessarily so. I mean, I think I described to you in one of my emails, I had done that very large analysis in our program and found that these, what we were calling the obesity paradox, or people who have a very high body mass index, BMI, which I'll let you describe in a moment, but they were healthy. They had normal blood pressure, blood sugar, 67% of them look perfectly healthy, even though they fit even into the obesity category. And in fact, as they got heavier, it seemed as though their cholesterol and everything else started to come down. So that's what you're describing when you talk about a metabolically lean.
So yes, so I just like to qualify. So the metabolically healthy obese, these are, as you say, individuals. However, their body fat distribution may be such where they have greater subcutaneous fat and less visceral for their overall,
Right.
let's say, level of fatness. And
Right.
that is what places them perhaps in a healthier state. So maybe they have better insulin sensitivity, less
Right.
lower levels of inflammation, all of that.
So I don't know if you remember when Catherine Flegel published
Yes.
her data on the lower extremity body fat compared to the upper, and she made a big splash in the world. She was for the Centers for Disease Control, and she made the statement that you could have a high BMI, but if the body fat was located in the lower extremities, there didn't seem to be any problem. Or is that? Could you comment?
So yes. So when we think of subcutaneous fat, it's obviously distributed throughout the body. However, the subcutaneous fat that is located in the, let's say, the hip and the thigh regions, and that often is the profile of women versus men. Men tend to have more the apple abdominal when obesity, whereas women, it's often the pair, which is reflecting greater subcutaneous fat in the thigh region. And we know that persons with greater subcutaneous leg, and that would be measured by DEXA often in the studies that perhaps Dr. Flegel is referring to, those individuals have a better metabolic profile.
Right,
Correct.
right. So you're saying you could have large amounts of lower extremity body fat and be perfectly healthy, is basically what you're saying.
So yes, yes.
So I have a question, an age old question for you. Why? Why do women? I have been asked this question 10 trillion times. What is your explanation as one of the world's experts? Why is it that women collect more fat, subcutaneous fat in their lower extremities than men don't? It doesn't seem fair. What is the story there?
So I think it may be in part related to just the function, female function of childbirth and all of that.
Okay.
This does not mean that there are no women with abdominal obesity.
Oh, yes, of course.
We see both. It's rare that you find men with lower body obesity. The proportion of men with obesity who have lower body is much, much smaller than,
Right.
yes.
Okay. Got it. I want to return to something you mentioned a moment ago, which was the two compartment model. When you were describing that, you were talking about fat and muscle. Is that the two compartment model that you refer to?
So I want to be very clear. When
Yeah.
we talk about measurement methods, the simplest measurement methods are based on this two compartment approach or model, which assumes that body weight consists of fat. And then everything else, if you subtract fat from body
Ev-
weight, you get everything else, and we refer to that as fat-free mass. I want you to be
right.
aware that that fat-free mass has, that's where the muscle is contained, but there's a lot more in there than just muscle that falls within the lean tissue.
Okay, right. Okay, so let's get to measuring this for a few minutes, since that is certainly one of your areas of expertise. And your lab, when I used to go downstairs to the basement where they stuck you with all your equipment down there, you had all sorts of devices for measuring body composition. So would you mind commenting for a few minutes on your observations about your experience with it, the types that maybe give you the most benefit, and then we'll move to what people can do at home to measure this, because obviously they're not going to be able to all come to your lab. So if you could talk just about how we measure these things and how you use them in your research and measure those.
So there's simple approaches to measuring body composition. The simpler approaches tend to be these two compartment, and as a result, the degree of precision or reproducibility may not be as good as what we require or expect for research. So when individuals go into their physician's office, it's like measuring weight. They stand on a scale, but they've got clothes on them. You know, what is the precision? For body composition, it's somewhat similar. So, for example, Skin folds. Skin folds is one of the oldest measurement methods around. Goes back a century and a half. It's using calipers, 3 to 4 sites of the body, and determining the thickness of the subcutaneous layer at those 4 sites, and then using equations that have been developed, coming up with an estimate for percent body fat. Those are good, but the margin of error may be greater if those 4 sites that are used are not perfectly representative of where the fat is in that individual located in the body. That said, if you're going into various schools and you're going to be measuring different children and you don't have a lot of resources, they're fine. It'll give you some index. That's at a simple level. At a more advanced level for research, we're looking and we need measurement methods that can target specific depots or specific tissues or organs in the body. So skin folds are not going to be able to do that. There are certain assumptions with these 2 compartments. For example, a major assumption in a lot of these methodologies is that the hydration of the body is normal, and that water in the body is found almost exclusively in the fat-free mass compartment. Now, by and large, healthy individuals, hydration is approximately 73% of the fat-free mass compartment. But if for any reason that hydration is different or altered in individuals, these methods are not able to detect that, and therefore the percent fat result that is produced is not going to be accurate. So, yeah, go ahead.
Like the calipers, you mean?
Like the calipers.
Right.
The same applies to bioelectrical impedance analysis.
Well, that was my next question for you.
Okay.
If you could describe that for folks.
Now, this area of there are many, many new devices that have come onto the market through the decades, and I'm saying decades now. There's bioelectrical impedance analysis, there's bioelectrical impedance spectroscopy. So this approach to technology is certainly improving. But many of the devices that are going to be available to users for home use, again, assume that the hydration of fat-free mass is the set number. It assumes when someone steps on there that they're not wearing clothes, that they have emptied their bladder, that they haven't just run 5 kilometers or 10 kilometers, that they are normally hydrated, that they haven't eaten recently. There's a lot of these assumptions. If those conditions are not standardized, it's going to affect the result.
Can you describe for people just the mechanism of the bioelectric impedance? How does the scale work? Because we do have a lot of folks in our program who are buying BIA scales and so forth. And if you could just talk for a moment about how they work and the error associated with them, hydration being one of the issues that confounds the result.
So I would have to say, because there's so many scales out there from different companies, I can't address the error, because for me to address error, I would need to have tested it. So basically, it's based on this 2-compartment approach, where it's assumed that when an electrical current is passed through the body, it's going to be essentially resisted by the fat in the body, because remember, fat is relatively anhydrous. If you mix water and oil, they separate. That's the assumption. So therefore, it assumes that the water in the body is in the fat-free mass compartment. Okay, so so there's certain assumptions built in the software that 73% of that person's fat-free mass who steps in the scale is water. The person steps on, their weight is measured, an electrical current is conducted by the water or resisted by the fat. There's equations, there's sex of the individual, the age of the individual is in there, and a percent body fat is produced. So that's essentially, yeah.
Okay. And one last question about BIA, because I'm asked this all the time as well. Because, and again, I understand what you're saying, that you would have to test each one to
Yes.
determine the error. And I get that completely. On average, would you say that the BIA devices where you stand on it barefoot and you hold on to the handles, would you say that that might have less error than just standing on it with your feet?
So I think intuitively it should have, because
Right.
the contact is being made by four parts of the body. So intuitively, yes, I would
Yeah.
say it does. Um,
Okay. Okay, because we also, in fact, I did a study once with Mike Rosenbaum, and we just actually used a handheld device. It wasn't even we didn't even have the subject stand on anything. They were just holding it, and it was good enough for the research. So,
right, right.
okay,
And I would like to add that I
yeah,
think one
please,
of the important points I want to make here for individuals who are monitoring their own body composition at home.
yes,
If you use the same instrument and it's placed like a scale in the same location, no one else steps in it, no dogs or children play with it, where the calibration is kept, it's calibrated. And you weigh yourself under the same conditions, and that should be in the morning after you have got up from bed, you empty your bladder. That's the point of the day that we weigh the least. Then remove your clothes, step on, and get your measurement. And if you consistently do that, it's your ability to track change over time that really is most important. And especially if someone's going on a weight loss program, does it matter what the actual percent fat is that you're starting out with versus what the change is over time? So if you can be confident that the change you're seeing is accurate, that's what's important.
correct. Right, I'm with you 100%. It's the change that we're looking at, not necessarily the accuracy, because we know that if we sent them to your lab, we would get a more accurate reading.
Right.
But it's the change. So even if there's error, we're assuming that the error is consistent.
That's
So if it dropped 5%, it dropped 5%. It just may not be that it is 20% or 22%, or
right.
that's what you're saying. Is
Yes.
that
That
right? And
is
I,
correct. That
yeah,
is correct.
Yeah,
Yeah. Go ahead.
I mean, I guess for the most part that's true, but I do have the scale that I currently use. It's one of the ones that does have a handle, the Withings one. I do weigh myself at the same time every day. Nobody messes with it. It's in my gym next door, and the results can be different. In other words, this one measures water volume, lean mass, fat tissue, and visceral fat. And like the visceral fat, it keeps going up and down, up and down, up and down. So some of the metrics are not consistent, and I can't necessarily say that the error is the same every time. And I do get DEXA scans done, so I know at least what it was in July. I'm going to go back in October, but it's wildly different than what the scale shows me.
So that, you know, that's unfortunate, but it's one of the reasons why, for research purposes, these scales would not pass muster. Yeah.
okay. In terms of, let's talk about weight loss for just a moment. Um, when you conceptualize body composition and weight loss, would you say is there a role for body composition in weight loss? Does more muscle help more? Or how would you, even metabolic rate? How would you kind of characterize it if you could?
That's actually a great question because my goal is to gain more muscle so I can eat more ultimately. So if I'm on the wrong path, I need to know because it's a lot of work to build muscle.
Yes, I would agree. First of all, I think the role that body composition plays, if someone, let's say I'm talking about someone with obesity and their physician has said you need to lose weight, is knowing body composition important? I think not so much. I think knowing body composition becomes an additional motivational tool, because when you see that number on the scale, so not just weight, but you see that percent fat, because everyone knows about percent fat, that it's beginning to decrease. That that makes you feel good. You feel you're making progress here. There's such, I really can't give one single answer to your question, Rich, because it depends on where you're starting out. Individuals who are starting out with high obesity levels, meaning high adiposity, they need to lose fat. That's, and many of those individuals have quote unquote normal lean mass. Okay. Now, that's different. And I don't want to deviate, but I want to get this in here. This is different to individuals who have obesity in the presence of sarcopenia. Now,
And define sarcopenia for our listeners.
okay, so an individual who steps in the scale and this individual has elevated weight. They also have elevated fat mass, okay? Normal obesity will have also elevated lean mass, because when you gain weight, you never just gain fat. You always gain lean, okay? And we can talk about that. An individual with sarcopenic obesity, means that they have elevated fat mass and they have decreased lean mass. Now, why is that important? Well, muscle, lean tissue is essential for function. Okay, and it doesn't matter whether you're a young person, middle-aged, or older individuals. Functionality is hugely important. And losing weight when you have excess weight is important for functionality. Think about osteoarthritis of the knee. Think about activities of daily living for individuals who are older. So sarcopenia basically means that you have, for your body weight, you have lower lean mass than is normal. Okay. So you may ask again, what is the relevance of knowing body composition if you're going to lose weight? Well, this is one area that becomes very important, because if you have reduced levels of lean mass, you want to know that, because losing weight is going to push it down further. And it makes it, in fact, more important that your weight loss includes efforts to exercise, to increase your muscle, maintain/increase. And I would say for many people, start off trying to maintain what you have, because the concept of increasing is daunting if you're in a hypocaloric state where you're trying to lose weight, but start off trying to lean.
You have said so much here. So just briefly, when you say functionality, you're talking about activities of daily living, climbing stairs, moving around, carrying packages and things. That's what you mean, right?
So that is what I mean, because for most young people, that's not such a big issue. But if young people are losing a lot of weight early on because they need to, they've got greater obesity levels. Even if they maintain that weight loss, the chances are that their lean mass may not be where it should be as they age. If it's happening in middle ages, or in fact people are older, it's much more detrimental, because muscle is also attached to bone, and there's important relationships there between muscle and bone. Mm-hmm. So, yes.
So when people are losing weight, you're suggesting that they exercise to maintain the muscle that they have, because when they lose weight, they're losing fat, but they're also losing muscle. That's what you're...
So sort of globally, the percentages that we talk about is when individuals lose weight, and I want to emphasize this is under healthy conditions where the diet is nutritionally complete, high protein preferably, but nutritionally healthy with appropriate macronutrients, that the composition of the weight loss is 70 to 80% fat, 20 to 30% lean. Also, when you gain weight under normal conditions, the composition is the same. It should be
as it goes higher, you mean?
As it goes higher. That may change. We have evidence to believe that does change in the elderly. But it may be part intentional versus unintentional weight loss, and I don't want to go in there. But when older individuals lose weight, the percentage that is actually lean often is higher.
It's
And
higher.
then when they regain, what they regain has less lean. So it
Right.
becomes a vicious cycle.
So Dr. Gallagher in our lab years ago did that study where he measured body composition, body fat in people who dieted, people with no exercise, where they did aerobic exercise or they did resistance exercise, but everybody lost about the same amount of weight. But what he found was that people who did resistance exercise only lost about 8% of their weight from
Right.
lean. And so I guess the question is, it's possible then for people to lose weight. And if they're exercising, if they're doing strength training, weightlifting, they can preserve that muscle, the lean
So
mass.
that is exactly what has been found, and that is exactly what is needed, although it's challenging.
Yes. So you would say that that's important because of functionality, but what about the metabolic difference between muscle and fat? And as people are losing weight and losing muscle, how is that affecting the metabolic difference and their metabolism in general, maybe, if that's the right question?
So that's a tough question to answer. I think what I want to say is the following is the metabolic rate, the amount of calories burned by if you have a kilogram of skeletal muscle is about 13 kcal. So divided in two for pounds. So it's about, 6 kcals or calories per pound of muscle.
Okay.
If you have a pound of fat, number of calories that is burned by a pound of fat is about 4.5 kcals, which is about 2 calories per pound. So you then this only becomes sort of, you need to think about this in the context of how much fat is in a person and how much lean mass is in a person to understand if you're losing weight, okay, what's the implication of this? What I want to say is often in the literature you will read, well, skeletal muscles is high metabolic rate tissue. I think that's a bit of a misnomer. Compared to fat, yes, has a metabolic rate that is about 3 times higher. But you have substantially more fat in your body than you do muscle mass. Okay? So that's what I want to say about this. So yes, when you are losing weight, you want to lose fat and you want to maintain as a minimum your lean. Better still, better build it, gain more, but that takes a lot of work. And I think many people just starting out, or unless they're not what I call the usual individuals, they're more fitness focused,
Right.
most people won't do it.
One of the things we do at Transformation Weight Control when people start losing weight is we don't expect they're going to start training for marathons or go to the gym and pump iron for 2 hours. But I will show them something as simple as a wall press just to get them started on the idea that they can build muscle. And they will come back to me 5 weeks later and say, Rich, look at my arm. I can see my triceps, right? Because all they've been doing is just that. So I know you're saying that it's a lot of work, but it doesn't have to, I think it's important to emphasize that you don't have to go to the gym and spend an hour and a half there. Is that fair?
So I think that's fair, but I think the literature and the media, that's
Yeah,
not what's put forth. And
right.
it's like you need to have a gym membership and you need to go X number of days a week.
Yeah,
And real life, and I can speak to this because of the studies, our populations, these are very busy
yes,
individuals with families, with jobs, and now they're adding on something else. So what you're proposing is exactly what's needed. Make
yes.
it easy.
Yes, because I am very down on the media and their sensationalism, and they find the one person who something terrible happened and they explode it, and then it shows up on Reddit and TikTok everywhere, and everybody believes it. But the point of our conversation and our podcast is to dispel these sorts of myths, that because the media, people just listen to it. So, okay, we're on the same page. I agree. People are busy. And if I tell them, if I give them the message, you got to go to the gym, this is not going to work. Whereas there's always a wall somewhere that you can do a wall press. I mean, I have folks who are doing it in the shower. And as long as they don't slip, I'm really happy with it. And we might get them some of the exercise tubing. That would work as well. Yes? Yeah,
Yes, absolutely. Absolutely.
good. So go ahead, Alex.
Just to go back to something you were talking about earlier, so fat versus muscle and metabolic rate. So I know that, and I've seen this based, on my watches and tracking things. So, I start out with maybe a goal of burning 1,300 active calories per day, right? As I lose weight, and I've lost about 45 pounds, that goal is much more difficult to hit because it looks like I'm burning less calories because I weigh less.
That's correct.
So, how does that fit into everything? Because from on the DEXA scans, I'm gaining muscle, I'm losing fat, but at the same time, it looks like my metabolic rate is slowing down, not speeding up. And that might just be a thing on the watches and how they track things, just purely based on weight. But I just see it's much more difficult to hit 1,300 calories again. Whereas when I weighed 250, it was pretty easy, an hour and you hit 1,300. Now it's more like 2 hours.
Okay. So I think, not knowing about what you started out with or whatever your, you know, natural, I don't want to use the word natural, but whatever that was to begin with, you may be in part touching on, the phenomenon that losing weight, everyone, maybe individuals have a set point, and once your body, you lose weight and you get down to a certain point, it becomes more and more difficult to
Yes.
lose further, and it becomes difficult to maintain it.
That struggle is real, and that's where I am today.
So, and this, which is something that maybe you're going to ask me about, one of our current studies is designed ongoing to try to address this. So I'll wait.
Well, I want to make sure we get to that, but it was a perfect segue. This question Alex asked was those biological compensatory mechanisms that the body creates to help prevent more weight loss. So if you wouldn't mind speaking to that for a moment and how body composition plays a role. So for instance, the compensatory mechanisms where the body slows metabolic rate, or it increases ghrelin to make you want to eat more, those sorts of compensatory mechanisms that Dr. Rosenbaum and Leibel have characterized so nicely. Is there a role in body composition for that in getting through that plateau that Alex is sort of talking about? Because naturally, the compensatory mechanisms are there for all of us. Is
Right.
that fair?
So, so, I would say the following: that what we know from the literature is that there's something called metabolic adaptation that refers to decrease. There's a decrease that describes essentially an increased efficiency and energy expenditure that people in the reduced weight state, and I think, Alex, you would represent someone who's in the reduced weight state, that you may utilize less energy than predicted for your new weight. And your watch is based on what's predicted. Okay? And what might be causing this? Well, we're not sure, and that's why we and others are doing studies to try to understand that. One thing may be appetitive adaptation. Okay, and that describes the potential drive that exists to increase energy intake that's beyond what is needed to maintain your reduced weight. I don't know if you've experienced that, but most people, they do, and that's why they start in part to regain. The other, so those are there's the metabolic adaptation and there's the appetitive adaptation. What's important to sort of keep in mind is that the weight reduced state, at least from our perspective, is most likely a distinct scenario from from your original weight state. We tend to think it's just, okay, you're at a new weight, but physiologically, biologically, it's a very different state. And therefore, if you want to try to maintain this new reduced weight state, it requires different approaches or therapies to do that compared to losing weight. And Rich, what we're trying to do in this study,
Yeah.
we're trying to get to mechanisms because it's based on the following, very simply. Losing weight's not difficult. What is very difficult is keeping the reduced weight off. And I think, Alex, your comment there was absolutely appropriate. So what are the mechanisms that are potentially at play in the reduced weight state that may be driving that weight regain? So there's physiological parameters. We believe there's metabolic. That's why we measure different energy expenditure in the free living state and metabolic chambers. There's molecular potential mechanisms, appetitive.
Can you, I don't think anybody's going to know what you mean by appetitive. Can you just
So
define that real quick?
appetitive relates to eating, hunger, drive to eat. Let's say foods that may be craved. Remember, the gut and the brain control so much with regards to what we eat, our weight. Once you start to lose it, everyone will report, it's a struggle. If you can get through that first month, 6 weeks, good. But what is it? The gut and the brain are not happy. They do everything in their power to, I say simply, to convince you this is not a good idea. And if you can get over that, you're rolling. And then you get somewhere, you get 12 weeks, you get, 20 weeks, maybe you keep the weight off. But for many people, they can't sustain it. And the majority will regain some or maybe all of that weight. So the purpose of this power study, as we call it, and it's called the power study, basically it refers to the physiology of the weight reduced state, is we have everyone lose weight over a 20-week period. They have to lose at least 7%, many are 10%, 15%. And then they're on their own for a year. We are not allowed to intervene. We have 4 critical measurement time points where we do intense metabolic phenotyping of all descriptions. And we want to see at the end of that year following weight loss, what is it that differentiates those who've been able to keep the weight off from those who've regained some or all of the lost weight? Because it's not one, and it's my belief, it's not any one particular factor. I just mentioned out some. It could also be psychological, social, behavioral. There's multiple. But we're attempting to try to come up with some signals as to what's going on.
So this is probably the most exciting thing to hear from someone who is at the core of research in one of the biggest problems in weight management, which is exactly what you're talking about. So can you let us in a little bit on anything that you've observed so far as to what might be one of the variables that does affect this, and then what could we do about it? Have you gone that far yet?
So we're not that far. We've enrolled, it's a 2-site study. One is being done here at Plum University Medical Centre, and I want to acknowledge my MPI colleagues. You already mentioned Drs. Leibel, Rosenbaum, and also Dr. Mayer. And then the other site, clinical site, is based in Philadelphia. It's UPenn and Drexel, and then Dr. Susan Roberts at Dartmouth is involved, and
Sure.
Tufts University is also involved. So we have enrolled about 50, I would say maybe 4% of our targeted population. We have a ways to go. All of the data are being banked. So there's a data coordinating center, so we don't get to look at it until the entire study is over. And it is going to be a very exciting data set when it's done.
We look forward to it. So how long will it take? I'm going to just ask you. How long? Come on, give us the answer.
I hear you. As long as the NIH continue to,
Well,
it's going to take, I anticipate, another 2 to 3 years to
Okay. All
get
right.
the data where we're analyzing it.
All right, we could wait that long, and then we'll figure out interventions to change it once you've identified the factors. Is that the idea?
Yes,
So this is
that's
like
correct.
translational research. It's what can we do with this research to make our lives better. So
Yeah.
you are at the heart of this, and everybody's going to wait for your research. We all want to know the answer to that. All right, good. Let's switch gears just a teensy bit. Number one, is it ever too late to gain muscle?
It's never too late to gain muscle. It's never too late to do everything in your power to exercise or to modify your diet, get high protein coming in. And I always think of older individuals, because you don't want to injure yourself, but it's a silent sarcopenia, it's a silent condition. It's like osteoporosis. You don't know what's happening until you fracture for osteoporosis. With sarcopenia, there's not even diagnostic criteria. And so many, incidences that happen with elderly in terms of falling, etc., may in fact be reduced muscle related.
Yeah.
So yes, that's important.
Yeah, uh, falling is about the fifth leading medical expense in the country. People don't are not aware of just how tragic it is for people falling and how much what you're describing could change that, building muscle at any age. And isn't it true that it doesn't always have to be that you have to get big muscles to get stronger or to get the muscle more active? The central nervous system is playing a role in this as well. So that, like Dr. Fiattarone, her studies in the Boston nursing home, people with up to 98 years of age gained 100% strength,
That's, that
right?
is, I, there's no doubt. Just doing anything, moving, it is so essential. It's even helping people sit to stand. Okay, getting
Yeah,
from a seat and getting up.
yeah,
It's not just legs, but it's arms as well. And at the very end, for many older individuals will say, you know, at the time that they have to progress to using a walker, they say, well, I know what I should have done years ago to
right,
delay this.
right.
And we're all very good at talking about what we should do.
Yeah, yeah, we're just started last night a 6 week aging workshop, a healthy aging. And so our psychologist and our dietitian will be doing it, and then I'll be doing 2 weeks of exercise. And I can assure you that I am going to be speaking about this sort of thing because it is never too late, but it'd be better to start when you're 60 than when you're 90. But nonetheless, it's never too late. And it's so important that we do that. All right.
Yes.
So,
I could just add one more
yeah,
thing.
please, please.
If you were in a position, in the studies that have measured changes in muscle or changes in lean and have you measured changes in strength, strength is lost much more quickly
Right.
than actual muscle. So don't assume that they're proportional.
Correct. Yeah, no, no. I think the central nervous system has a big role in this. Yeah.
Yeah.
Okay, I have two main areas I want to sort of get to for sure. One is a little bit controversial, which is the question I'm asked all the time: what should my body fat be? And my response, and you can let me know if I'm on board with this or not, is we don't really know what the ideal body fat is. And I know a researcher, Dr. Dympna Gallagher, and she wrote a paper once many years ago about trying to figure out what the ideal body fat should be. And I'll tell you this, I was at a conference with her one day and I walked up to her and I asked her, and by first name, on a first name basis, what should these folks, what should people, what should their body fat be? And you, I don't know if you remember this, but you almost forgot that you had written that paper. I had to remind you that you wrote that. And then if you track the literature, your paper was one of the last on this subject. Because if you go online, you will see 1,000 different tables about a man at 45 should have this much percent body fat, and a woman. Shed the truth for us on this.
So I don't have the answer, and there is not an answer to that because
Right.
it's not when you talk about what's average or what's healthy. Individuals vary so much, okay, and they vary by age. There's a very definite sex female male differences in there, and where in the world they're coming from. We talk about ethnic race differences in body composition, but those are real. Populations that have naturally a higher percent body fat, that's okay for them. They don't have the associated risk that perhaps individual United States have. So I don't have an answer.
Okay.
I know that there are data published by the CDC in their vital and health statistics, data that used N. Haynes,
Yep.
2000, I think it was an older N. Haynes, but again,
Yep.
they may have updated. They have their values, and of course, appropriately, they're broken down by sex and they're broken down by age.
Right. Well, I tell people that if they find a table that tells them what their body fat percent should be, I say to them, this is true, I say, unless the reference for the table is Dr. Dympna Gallagher, then do not believe it. Because there's just too much variation, and we simply don't know. Because we have healthy people who have a lot of fat. Yeah, it's like that. Okay. Last point, and I'm sure you must have an opinion on this by this time. What about the new GLP-1 medications? We're running a weight loss medication support group I started 18 months ago. I have never been interested in the weight loss medications. The body always figured out a way to beat them up. But not these. These people are losing a lot of weight consistently. There's no plateau. They just lose. But one of the controversial issues about it is they're losing, as we've discussed already, muscle. So can you give me your opinion about the GLPs? What is your thinking about those medications? Because it's possible that these medications could not only help people lose weight, but possibly prevent regaining it. So could you speak for a moment? What's your thoughts on this?
So, I know the literature. I know
I'm sure you do.
The studies that have reported on body composition output. I would say to you that the technologies employed have been primarily DEXA and BIA. So again, I bring you back to the issue that I mentioned to you, that hydration is assumed, and this applies to DEXA as well. It's assumed that hydration is this fixed number. With GLP-1s, with medication, there's no consideration given to whether hydration is or is not different.
Right.
One of the side effects, severe nausea, vomiting, right there. So I would say that it's too early yet, based on the published literature, to be able to say what are the true effects of these medications in body composition. For sure.
Yeah.
For sure. They affect weight, and that is good. I have no issue with them. I'm not quite convinced yet, in the studies that report on that there's an increase in muscle mass.
Yeah.
I think I need to see more data.
I'm good. I'm glad to hear you say it. You confirmed what I believe too, and what I teach, because we just don't know yet. And we know that lifestyle change is important. It contributes to the losing of weight. The GLPs are not the panacea. They're not the only answer. Lifestyle changes still need to be implemented. So
yes.
We're on the exact same page. Yeah.
Without a doubt. I know we have individuals coming in who just their lifestyle choice is not to go use GLPs.
Right.
Right. And
Yep. Yeah, we still have a lifestyle change program. It's harder to recruit for it, I'll tell you that. People want the GLPs. But I'm glad to hear you say that, because it's how I think about the literature as well. We just simply don't know enough at this point. And the media just grabs onto these things, and I believe there is what I call a medication bias against those medications, and which by association translates to the bias against people with obesity. That's how I see it. And that's why the media grabs onto something and says, oh, if you take this medicine, you're going to lose so much muscle, your bones are going to fall off. This is not the case, and we just don't have accurate data for these sorts of comments. And it really makes me crazy when I hear the media sensationalize things that's pure fiction. So I think you and I are saying exactly the same thing, and it's a very important point.
Yeah.
Alex?
And I hear that and I get it. I'm not a fan personally. I've tried these drugs twice, and both times they were the compounded ones, and I just didn't have a good experience. I quit twice after about a month. But what I want to say, I do know some people that take this that were prescribed because they have like either diabetes or whatever the condition. Idea of exercise does not come up. Like, everybody I know, well, I shouldn't say everybody. I do know one person who's recently lost a lot of weight on that medication, and he does exercise. But I also know at least two people that they take it and they just assume the drug will do all of the magic and they don't have to do anything else. And so I don't think that works, because I think that's the majority thinking of people. They're like,
That,
hey, I'm going to take this and it's the easy way out because it's just going to naturally
yeah.
stop me from doing stuff.
Correct. No, no, no. I mean, it is our observation and part of our support group. People are bewildered by the amount of weight and normal appetite regulation, but we're helping them with those lifestyle changes too. Because in fact, there is some data to suggest that if you add lifestyle change like physical activity to the GLP, you're going to even lose more weight. And of course, the health benefits and so forth. Okay. All right. We're really sort of getting short on time here. Is there anything that you'd like to comment on, Dr. Gallagher, that we have not covered at this point? I mean, you've been doing this your whole life, your whole adult life. Is there anything else you want to just tell the listener that we haven't covered or that you think is important for us to know?
I would say, if you are on a weight loss journey, especially for medical health reasons, don't fixate on, you know, numbers related to body fat, etc. Just focus on losing weight, because without even knowing your body fat or your muscle mass, the data are overwhelming. You lose weight, you're going to see gain significant improvements in vital health factors.
Good.
However, you know, it all comes down to what the longer term plan is, and certainly knowing your body composition, as I said, may be motivational. When it comes to lean, I think, yes, if for some reason you've got reason to believe that you don't have as much muscle, or you're feeling that you're weaker than you should be, then yes, act on that.
Okay.
And yeah, that would be my only comment.
That summarizes it very nicely. And from a person who has spent their career working on this, to hear you say, don't worry about your body fat so much, I think that's quite profound. And I hope people take it to heart, because you, of all people, know the best about this issue. And to hear you say it, I think is a very strong statement. So I appreciate your insight into that. And I also appreciate the insight that the lean mass and the strength and the functionality is just something that's going to improve the quality of our lives. And that's what we're looking for, no matter what we weigh, frankly.
And the same applies to children.
Yeah.
Okay, and don't have time to go there.
No.
But, parents should be aware that children from a very early age, if it's evident that, that they have a higher BMI for their age, and that there's concerns by their pediatrician of carrying excess weight that they may not lose, don't worry about the fat. Think about the function. Get them out there. Make sure that they're active, happy children. A healthy diet, that is key, especially in childhood.
You have spent some portion of your career studying infants and children, and I think we'll probably have you come back and we can talk just about infants and children, because the reality is almost no one knows what to do with this problem. And I think your insights could help parents understand a little bit more about what to do, because it's up in the air. We just don't know about, prevention and treatment and obesity, children with obesity. And I've talked to Dr. Kathy Keller, many times about this, and she is an expert. So I really appreciate your insights on that. Thank you very much. Okay, well, listen, this has been a treat. I hope people stayed around and listened the whole time, because, we're doing something here with this podcast that not a lot of people are doing. We are bringing on the real experts at the heart of the research, doing the real stuff. And there's no substitute for that, because I look around, I wasn't much of a social media person, and the things I see sometimes just make me nuts. It makes me crazy. And so the whole essence of our podcast is to bring someone like you who really does know and speaks the truth, and you can count on it. And I think that's the value of having someone like you come here and honor us with your presence to be here. So I really appreciate the time that you took to
Thank
spend
you
time
very
with
much
us.
for having me. It was a pleasure. Thank you.
Yeah. I always at the end give a little shameless plug about our weight loss program, Transformation Weight Control. Not loss, but weight control. And the new medication support group that we've been running for 18 months. Because what we have experienced is that people are completely bewildered and unnerved by the fact that they are getting normal appetite regulation. You used the word appetitive earlier. That's what we're talking about. Suddenly, they're not hungry. They feel full. They simply don't know what to do. They're feeling tired and fatigued and dizzy. And I calculate how many calories they're consuming. They're eating 300 calories a day because they just don't know how to compensate for this sort of thing. So that's what we're doing in our medication support group, and it's been very successful. And I would just love everybody to join so that we could educate them, because they're not getting the type of education they need. So people can go to transformationweightcontrol.com. You can reach me at Rich@Transformation Weight Control. We'll put that in the show notes. Would you have any interest in having people maybe wanting to be subjects or something in any of your studies? Would that be something they could find on your website or
So
somewhere?
when we're looking for research participants, it's posted to the Columbia University Recruit Me website.
Okay, Columbia University Recruit Me website.
Recruit Me.
So if people are in your neighborhood in New York City, or maybe in some of the other sites, it's possible they could become a subject in your studies.
So, for example, for the study I mentioned, if
Yeah,
they're within, we have people from within the tri-state area that come for its a year and a half study.
right. And you mentioned other sites as well in other
So the other
regions.
site is in Philadelphia,
Yeah.
so they could
Okay.
also.
So that might be something that people might want to consider, because you get a special attention if you're in a study like this. Yeah, that's wonderful. All right. Well, thanks again. This was just a pleasure. It was great to see you. I haven't seen you in years. The history here is that we worked together for so long, and it's been almost, I guess, 8 to 10 years or so that you got moved up to Columbia and we stayed at St. Luke's. And I miss our Friday conferences and the dialogue amongst all the researchers and scientists and everybody. And so it's a pleasure to see you.
Thank you, Rich,
And I hope you'll accept our invitation to come back at some point,
for sure.
because
Absolutely.
you have been a true joy. And you're so smart and so knowledgeable and so experienced. It's just,
Okay, that's enough now, Rich.
I've got one last question.
Yes,
What's for dinner?
I know.
I usually ask. Alex beat me to the punch.
Okay, nice meeting you, Alex. Thank you.
Well, we had Marion Nessel, Dr. Nessel, on, and the leading food scientist in the world. And I asked her, I said, Dr. Nessel, what are you going to have for dinner tonight? Because she is the food scientist of all food scientists, right? And you know what she said? I'm going to look in my freezer and I'm going to see what I have.
By the time I get home, it's just something to allow me to get to bed and to sleep, because mornings are very early here.
Okay, got it.
So
All right.
thank
Well, thank you again very much, and
Thank you.
it's truly been a pleasure, and I'm really glad that you agreed to do this. Thank you.
Thank you.
Take care.
Okay. Bye bye.